I'm Dr. Sabrina Siegel with the Neuroscience Education Institute, and twice a month I sit down with a renowned mental health care expert to discuss breakthroughs and best practices for treating patients with mental illness. In this episode of the Neuroscience Education Institute podcast, we are discussing ADHD Awareness Month. As most of you know, October is ADHD Awareness Month, and I have with me here today Dr. David Goodman. Dr. Goodman is assistant professor in the Department of Psychiatry and Behavioral Sciences at Johns Hopkins School of Medicine and director and founder of the Adult Attention Deficit Disorder Center of Maryland in Baltimore, Maryland. Welcome, Dr. Goodman.
Hi, thanks for having me.
Dr. Goodman, why do you think that there's traditionally been so much focus on ADHD in children and not as much on adults or even older adults?
Well, historically, ADHD has been a childhood disorder described 100 years ago, and then with the approval of Ritalin in 1955 for what was then minimum brain disease, ADHD has traditionally been a child disorder. We had previously thought that for reasons of mystery, ADHD went away when the child was discharged from the pediatrician. But we do know that from longitudinal studies, the first of which came out of Canada in 1988, that ADHD children will largely continue to have symptoms into adulthood. Now, the pharmaceutical industry didn't take notice of this until these longitudinal studies were published. And they then decided, look, this is a real thing, and we need to start applying the treatments that we've used in children to adults to see if they're effective. So over the last probably 20 years or so, clinicians have become more adept and aware of ADHD in adults.
What can be done to better diagnose seniors with ADHD, in your opinion?
So seniors is another category of ADHD. We have spent the last 20 or 30 years educating clinicians that ADHD in childhood often persists in 60% of children into adulthood. And yet, the focus in the last 20 years has been on adult ADHD. That is, patients ages 18 to 55. There has not been a lot of research until just the last few years on ADHD in patients over the age of 50. Now, most of these people who have ADHD were never diagnosed as children, nor are clinicians aware that patients coming into primary care complaining about cognitive complaints may actually have ADHD. So if you're not trained to look for something, you often don't see it. And that's the case for most clinicians who are aware of ADHD. But now the older adult comes in at 55 or 60 and complains about their cognitive changes. And the presumption by the clinician is this is age-related and or mild cognitive impairment or polypharmacy or medical illness related. And they don't think about ADHD in the older adults. If you look at the Amsterdam research and also research in the United States, the prevalence rate for seniors with ADHD over the age of 50 is about 3%. So comparatively, though, the prevalence rate for adults in the U.S. is 4.5%, and the prevalence rate in children in the U.S. is anywhere between 8 and 10%. So 3% of adults likely to have ADHD is relatively high and not diagnosed because clinicians are not aware. Now, let me just add the caveat. When I say ADHD in seniors, I'm not talking about a cross-sectional complaint where patients are complaining about inattention, distractibility, and disorganization or forgetfulness. I'm talking about someone who has had ADHD symptoms since childhood, and the track of those symptoms has been chronic, relatively unchanged, impairing, often observed by other people. Now they come in complaining because the cognitive aspects of their life are interfering and or they have gotten worse. They may have gotten worse because there's an age-related overlay, but they had previous ADHD as a child that continued throughout their life.
Wow, that's fascinating. And that sort of leads me to my next question, which is how do the symptoms of ADHD change across the lifespan, and what types of symptoms in seniors with ADHD could be mistaken for normal aging? You sort of touched on that a little bit, but if you could elaborate just a little bit for us.
Well, older patients will come in complaining about being forgetful. They're misplacing things. They forget about bills. They pay bills late. It just takes them longer to gather their thoughts. And to the unaware clinician, they'll say, look, this is normal aging. Don't worry about it. Or if they're on several medications, they may say this is a function of subtle cognitive effects from multiple medications. If you have medical illnesses that can compound the cognitive deficits, it gets ascribed to that. The symptoms for adults, though, are very much the same: forgetful, misplacing things, easily distracted, difficulty initiating tasks, difficulty staying on tasks. When they drive, they may be easily distracted. They may miss a red light or a stop sign. Family members notice that when they're in conversations, they drift. They're not staying in the conversation. They can't remember what they talked about 10 minutes or 15 minutes ago. So clinicians will say, look, this is normal aging, or let me do a medical workup. I can do blood tests. We can get a head MRI and see whether there's any explanation. Often the results are negative, and people shrug their shoulders and say this is normal cognitive decline with age. But again, you have to be aware to ask. And so in those patients, you can ask, as a child, as an adolescent, when you were in school, how well could you sit in class, listen to the teacher, keep track of what was going on? Were you easily forgetful, frequently misplacing things? Did homework get handed in late? Did you have difficulty finishing things? Did parents spend a lot of time overseeing you to make sure you stayed on track? Did teachers move you to the front of the class because of disruptive behavior or inattention? If you get those symptoms in childhood, and then you ask about high school, college, first job, through their marriage, you might then see that these symptoms have been tracking ever since they were children. And at that point, if the family history is such that their own son at 35 years old was diagnosed with ADHD, then it's very likely that you're looking at an ADHD picture. Now, that may be compounded by changes related to normal aging. However, if you treat these people, they get significantly better.
That's such great information to share with us. And I think that's what seems so surprising, to me, is that these are actually patients who have never been diagnosed. It's as if it's gotten to the point where the symptoms have really started to interfere with their life. But, and if you were to ask caretakers and family, they would say, yeah, they've probably had these symptoms all along, and yet they've gone undiagnosed. How does hyperactivity manifest in seniors with ADHD?
Well, the short answer to that is we don't know because nobody's looked at it. We do know, if you track children with hyperactivity and impulsivity, that the hyperactivity tends to diminish with age. So in childhood, the male to female ratio is 3-1. And that's largely because the males tend to be much more disruptive in their behavior. And that's what brings them to the attention of clinicians. But as these children age, the hyperactivity tends to diminish. They're not disruptive, although they may persist in being fidgety. They tap their feet, they fiddle with their fingers, they may play with a pen. And other people notice this, but it's not disruptive in the same way it is for children. When you get into seniors, we really don't know because we haven't looked at symptoms specifically in the senior population. I'll remind you that most of the pharmaceutical trials for ADHD in adults top out at age 55 or age 65. And in those age categories, we were simply applying the general adult symptoms and extrapolating to older age. But for the older adults with hyperactivity, we really don't notice. The other aspect, though, is impulsivity. So impulsivity may decline, but it declines at a much slower rate over time. And so it's hard to track, again, the level of impulsivity in older adults because you'd have to do a longitudinal study looking at patients over the course of 60 years, which is just impossible to do.
What would you say are some of the challenges in terms of just simply daily functioning that are unique to the geriatric population with ADHD?
Well, it's very interesting because if you're not a retired individual, you'll imagine that being retired is pretty easy. You sit on your rocking chair on the porch and you stare out into the world and you don't have much to do. Talk to retired people and they'll tell you first thing is that their medical care for them is a full-time administrative job. And if you've ever gotten statements back from hospitals and insurance companies, it requires a lot of sustained attention. Also, you still have to do your taxes. You still have to manage your money, your estate, your bills. You still have to coordinate with other people. So these folks will say, look, I'm having difficulty keeping track of what I need to do. It's very much the same complaints that adults have. The responsibilities and the nature of the tasks have changed, but the impairments and deficits are still present. Again, I keep coming back to the point that if you identify, diagnose, and treat these people, you can significantly reduce these cognitive impairments and increase their satisfaction and quality of life. It's a misnomer to think that, well, look, if you've had ADHD, you've had it your whole life, and why bother treating it now? Well, if you talk to somebody who's been treated at the age of 65, they'll say one of two things. They'll say, look, I function at a higher level and this is a better quality of life, and I'd prefer to be on medicine and treatment than not. And also, and more importantly for psychotherapy, is these people learn the difference between who they are and what they have. If you spend 50 years listening to the environment criticize you because you appear to be lazy or unmotivated, make careless mistakes, and don't seem to care about your work, you incorporate that into a negative self-esteem. If I teach you that there's a difference between what you have, which is ADHD, versus who you are, that's actually quite liberating. And the course of therapy, which is not written about in the scientific literature, is how do you resurrect somebody's self-esteem and self-image? Because with these people, they realize now that your ADHD is treated and I can accomplish so much more during the day, their sense of confidence goes up and they start taking on things they previously would have avoided. So the approach to adults with ADHD is being aware of what the possible diagnosis would be, getting some experience with prescribing medication, which I'm sure we're going to get into, and then also being mindful of the psychological aspects that these people go through as they transform from impaired ADHD to treated ADHD.
Mm-hmm. Absolutely. And yeah, with that, my next question was, what are the most effective pharmacological methods for treating ADHD in the elderly population? And would these methods differ from treating young adults? And it sounds like from what you said, in terms of at least on-label treatment, there's not that many options. So um, what would you recommend in your experience?
We have presumed that ADHD is ADHD, whether it's a child, whether it's an adult, whether it's an older adult. By the way, I stopped saying geriatric adults after I passed the age of 60. So now I refer to everybody. Now I refer to everybody as older adults, and geriatric is somebody who's 10 years older than I am.
Right.
In any case, though, the medications that we currently have approved for children and adults, we presume worked for seniors, and those are the medications we typically use. So we start with long-acting stimulant medications. Again, you're dealing with older patients, so you need to be mindful of the medical concerns. Often these folks will have other medical illnesses, diabetes, hypertension, cardiac disease, thyroid disease, etc. And also they're on polypharmacy, so they're going to be on several, 3, 4, 5 different medications. Those medical considerations are factored into the dosing of the longer-acting stimulant medications. There's no evidence that methylphenidate versus amphetamines is any more effective. So you make your best clinical judgment and that which you're comfortable with, and then you start slow. You start low and you go slowly, as we historically teach everyone to prescribe medication. Try to get the dose up to what would be considered a therapeutic dose. There's no blood level. There are no guidelines by weight for adults. So you just start at a low dose. You never know which patient is going to be an outlier metabolizer. So some patients can get by with a relatively low dose, and other patients need higher doses. Also, you have drug interactions, so you need to consider the drug interactions when prescribing. And then you track these symptoms as we do with adults. So I use the adult self-report scale, which is a screener, is a 6-question, and then the 18 items, which are the individual symptoms out of the DSM, which break into 9 inattentive symptoms and 9 hyperactive symptoms. I do that at baseline, and then I do that as they're on medication to track the symptoms. Now, here's a clinical caveat in regards to evaluating people. If somebody at age 65 comes in and complains about cognitive complaints, I'm not necessarily going to do an adult self-report scale given their complaints at age 65. I'm going to give them that self-report scale and say, I want you to fill this out based on your recollection of how you functioned in your 40s.
Wow.
Because if you do it at 65, you're going to get a contaminated result because they're including the age-related cognitive changes along with their ADHD.
Right.
I want to see what the symptoms were in their 30s and 40s. And then I can see what the difference is between the deficits and symptoms in their 40s and the deficits and the symptoms at 65. Because you have to consider both as the presenting problem. You'll be able to do something about the ADHD. You're not going to necessarily do much about the age-related decline. And that then goes into another question that I'm sure you would like to ask, and that would be, can I send these people for neuropsychological testing to make that distinction? And the answer to that at this point in time, with a couple of publications in this age group, is no. You cannot tell the difference in the isolated deficits on neuropsychological testing and describe them to either normal cognitive aging or ADHD. So you won't be able to make this diagnostic distinction on neuropsychological testing, and we've not been using that. This really becomes clinical judgment. So going back to the medication, you have the stimulant medications, you have the long-acting. If for some reason there's a financial issue and you have to use short-acting, that's certainly an option. And then you have the non-stimulant medications. Atomoxetine may be one. You have the alpha agents of guanfacine and clonidine. Again, there's more complications in using these medications because of drug interactions and hypotensive symptoms and the risks of unsteadiness, imbalance, and falls. So there's a lot of considerations in treating the older adults with ADHD and the choices of medications.
Wow. Thank you so much for sharing all that great information with us. What behavioral modifications in lifestyle could improve symptoms of ADHD in seniors?
So the lifestyle changes are very similar to the lifestyle and organizational changes we advise adults with ADHD, and that is you want to first accept that your memory is not as what it used to be. And the idea that I'm going to be able to remember this or that probably isn't going to work to your advantage. At some point in your life, you say, you know what, I'd love to remember this, but I'm probably not. And so let's write it down. A lot of people now with smartphones will use their smartphones, and it's easy to dictate a reminder into the smartphone. You don't really need to spend a lot of time texting everything into your phone. You can use the voice recognition, and that becomes very helpful. You can put in reminders in real time, and they'll alert you at some point in the future. Writing notes, visual reminders, visual cues on your bathroom mirror in order to remember to take medication. Having a coordinated calendar, a Google Calendar, so that you can coordinate with other people and you can see what they're doing and they can see what you're doing. It really becomes organizational and behavioral skills, putting things back in the same spot versus saying, look, I'll put it here and I'll remember. No, you won't. Let's put it back in the drawer that we know it's supposed to be in. You know, your grandmother used to say, there's a place for everything and everything in its place.
What could you say to the caretakers living with someone with ADHD?
Well, that was the next thing I was about to say, and that is that when caretakers are involved, it really is important to explain to them what this is and what it's not. People will worry that my parent is getting Alzheimer's, And often once we then treat the ADHD and they perk up and they're able to do things so much better, there's a big sigh of relief. But people with ADHD still have ADHD impairments. And the other is that some patients with ADHD have good executive function, and other patients with ADHD that's treated have poor organizational function. What does that mean? That means if you have ADHD and I put you on medication, your attention, your focus, your initiative get better, but you still have difficulty sequencing and time managing. That's important to make that distinction between ADHD and executive function, because ADHD core symptoms will respond well to medication, but the executive function tends not to respond well to medication. Why do you want to know that? Because if you don't recognize that distinction, you'll push up your dose of stimulant medication, assuming that the executive function should respond at higher doses. And then you end up with a patient on a dose that's unnecessarily high and induces unnecessary side effects, which will ultimately discourage the patient from taking the medicine at all. So in regards to the executive function, for the caretakers, they will sometimes need to step in and be essentially the executive functioning portion. Now, it depends whether the parent is living with a child or a caretaker, or whether they're living independently. Most people at this age are living independently, and so they're going to be less well organized. Specifically, when caretakers convey information, it should be written. It should be very legible. It should be in a spot where they're going to see it. So again, it's visual reminders and auditory reminders to cue the person to do what they need to do at that point in time. And then also understand, as is often not the case, that the person isn't doing this to you. This is something that they suffer with. So when they show up late, it's not that they're being disrespectful and they don't care. It's that they have difficulty tracking the course of time and the perception of the passage of time. It's like, I say, it's like yelling, pay attention to an ADHD patient is like yelling, look out to a blind patient. At some point, you have to understand that it's not unwillingness, it's simple inability.
Right, right. How would you suggest that we could effectively raise awareness for both clinicians and the general public about ADHD in seniors?
Well, I've spent the last 30 years doing lectures and educating clinicians on adult ADHD, and I'm now the lead author on the first review of the world's literature. We published this review in 2016. And so I've spent the last 3 years or so giving lectures and trying to insist that lectures include slides on adult ADHD and older adults. So I'm trying to educate clinicians. We need to do more of that. And as more clinicians become aware of this, then more people will be evaluated, identified, diagnosed, and treated. I'll tell you, it's a bit discouraging. There was a survey of memory clinics in the US, and 4 out of 5 memory clinics did not actively screen for ADHD in their population. And that's unfortunate, because about 3% of these people are going to have ADHD. Now, if you miss that, you miss the opportunity to effectively treat somebody and improve the quality of their lives and the quality of life of everyone around them. The other aspect of education and awareness is public media. So doing interviews, having print articles, having television programs that also highlight not only adult ADHD, but the extension of ADHD into older adults, and that those cognitive deficits that you have may not be a function of normal aging, they may be a function of ADHD. The other aspect is that families often diagnose younger. So the child gets diagnosed, the parent gets diagnosed, and then everybody turns to the grandparent and says, you were always like this, because when I was a kid, you showed up late, you didn't sign off on my permission slips. So
Right.
teaching family members who get diagnosed to start looking up the tree to see if somebody else has this disorder as well. So it's clinician education, it's public awareness, it's telling people who've been diagnosed to look at other family members and see if they want to get evaluated.
Excellent. Well, thank you so much for all this helpful information. And thank you for chatting with us today on this episode of the NEI podcast.
Thank you. It was my pleasure.
This podcast was brought to you by NEI. Not able to attend one of our live conferences? NEI releases recordings of the sessions presented at our 2 annual conferences, NEI Congress and NEI Synapse. Presentations are freely available online, and there are more than 90 CME credits available for NEI members. For additional information, see the link in the podcast description.